What happens to all the existing integrity recordings?
I don't know. I just heard the they're on there. I mean, you can export them onto into YouTube.
They're named on computer. The files.
Okay. I guess we need to find out.
It's like a wasted hour.
I haven't seen a memo. I haven't seen anything written. Just somebody said that they were going to a different.
Okay. Well, for anyone who is with us, sorry, accident on the bridge. So, okay, where did we leave off? Someone have set 2, slide 85.
John Brother. It's definitely a number. How many M&Ms?
Is that opening?
Like 7. A million.
Okay. So let's get down. You said 85. It's going to be that kind of a day. Let's try it again. Doesn't seem to like. Is there a faster way to get to 85?
You got your down there, you got your.
That might work. No. Sounded good.
It was there.
Yay. Okay, so I think you can do it. So we finished with that, which was, more widespread than you would expect Dowling-Dagos to be. Dowling-Dagos is usually flexural, comedones and pigment, and Gali is just an acantholytic variant of Dowling-Dagos. So a little more widespread than you would expect the distribution. Okay, so this guy is about 35. Oh. So what do you think?
No, it was in the neoplastic category.
In the neoplastic category, very good. You're hot. Very good. You're right on it. So, but what do you what do you think in the neoplastic category?
Like a giant
Yeah, exactly. Giant keratoacanthoma is what you'd put. Young guy, it's got the crateriform, the rolled borders. This kind of pale whitish look there is really characteristic for keratoacanthoma in the growing phase because the keratin is kind of stretching those things and squeezing the blood out of them. So, management-wise?
I mean, surgical excision versus injecting with 5FU and methotrexate.
Exactly. I mean, that's kind of where you are. So what they did was an incisional biopsy. This was Walter Shelley's case, and Dorinda pulled it out of his files in the barn to send it to me when I asked for it. Yeah, exactly. But I think this case better demonstrates the natural history of keratoacanthoma and that it exists better than, the picture worth 1,000 words kind of thing. Okay, that's him now returning right after the biopsy was done. So the biopsy was done and read. That's right. So now have you amended your diagnosis? So this is now, let's make it a week and a half after the biopsy was done. The incisional biopsy being side to side, kind of here to there.
It's okay.
And it was compatible with a keratoacanthoma. So this kind of explosive growth after biopsy, Do KAs do that?
Usually
No, they absolutely do. And do squames do that? Absolutely not. Squames don't care that you biopsy them. KAs get angry. Okay, so KAs exhibit explosive growth. So this is exactly the time not to lose your wits. Because at this point you say, this is the most horrible squame I've ever seen, send him to ENT oncology. They may be brilliant surgeons, but surgery is not the way to handle this. Because if you did surgery, you would now take out his columella, you would take out his entire upper lip, and greater than 2/3 of his lower lip. How are you going to repair that and make him functional? And okay, you're not going to make him functional.
He's 30 years old, man.
Exactly. So, and this guy is not isolated. I've seen, he's a little more dramatic than most, but I've seen lots of other people like this. And that explosive growth after the biopsy is not squame. It's classic keratoacanthoma. So, because at this point, the volume was just too much to inject with 5-FU or methotrexate, Walter put him on psoriatic doses of oral methotrexate. That's all he was treated with. Was, I think it was like 15 milligrams a week of methotrexate. There he is, now healed. The greatest deformity that they're going to have to repair is from the incisional biopsy that was done. It's not that he has no scar anywhere else, but at this point he's going to have some work done by facial plastics or by someone. But could you be anywhere close to this result had you attacked this surgically? So, question 1, do keratoacanthomas exist as a unique entity? I would argue that question's been answered. The answer is yes. Are they a self-involuting tumor potentially, and does that affect management? But it depends where it is. If it's an old guy on the arm, cut the thing off. If it's something that is occupying 2/3 of someone's nose, which I've seen numerous times, or an entire eyelid, which I've seen numerous times, then treat it differently. So I had one patient with Mirturi who had gut cancer, had a couple of sebaceous neoplasms, but the worst part of the syndrome, which it is for many people, was the keratoacanthomas, which just ate up her face. So she came in with both eyelids and her nose basically completely replaced by keratoacanthomas that had come up over 3 to 4 weeks. I mean, she was constantly in. And we were talking about ways to approach it. And she said, when I was treated for my gut cancer with 5-FU intravenous, all my KAs melted away. Do you think we could talk my oncologist into treating me with the 5-FU again for the facial KAs? And he did, and all of her facial KAs melted away. And it wasn't that she didn't need some work on her nose and eyelids, but they were saved instead of gone. So for some people, it matters. So how do you predict it is the next thing. If there is acantholysis, it is not a keratoacanthoma. It's not going to involute. KAs have rapid growth, are crateriform, have hypergranulosis in the center of the lesion that are follicular based. They begin as PEH of follicles, that hypergranulotic, that's not a word, but PEH with hypergranulosis of the follicles centrally merges into and becomes the crater, which grows rapidly. And you can see it in various stages of that. They squames push their way into the dermis. KAs pull their way into the dermis along elastic fibers. And you see that elastic trapping. They have EOs rather than plasma cells. All of those, and the neutrophil microabscesses. So there are lots of characteristic things we look for histologically as well as the history, and then it is predictive of terminal differentiation. So terminal differentiation is what you get in leukemias when you put them on all-trans retinoic acid and the immortal white cells become terminally differentiated to neutrophils that are now mortal and die. And the terminal differentiation of a keratinocyte is keratinization. So a Ka is arguably a type of squamous cell carcinoma that is capable of keratinizing itself to death. And you can trigger that terminal differentiation with drugs such as methotrexate and 5-FU.
Psoriasis work or not?
Not so well. I mean, I've seen people with eruptive KAs like on the legs. There's one guy with a Ferguson-Smith type that has been managed by a number of people in the department here who he's still erupting on soriatane. So I just injected them all with 5-FU last time I saw him. Because he can't, I wanted to do, he's mainly arms and legs. I wanted to do arm and leg uniboots with 5-FU. He can't afford the cream. I mean, this is a guy who drives in 3 hours from a rural area, and he can't afford even compounded at Tidewater. He can't afford the $35 for the 5-FU cream. So we just injected everything. So, okay, so that's kind of an illustrative case. Okay, so Sean, what do you think?
So it's kind of yellow brown street, like erosions or thin plaques.
And are they randomly distributed or are they clustered?
Clustered.
And what would you refer to that kind of clustering of round lesions? If you were to describe that distribution? Well, one might say herpetiform, and they're somewhat umbilicated looking as well. So why do we call that distribution herpetiform? Exactly. And in fact, all sorts of herpetic things. So like herpes simplex, herpes zoster, and dermatitis herpetiformis all cluster in little groupings and clusters of little round lesions like that. So in this case, in an older person, what are you thinking?
I mean, I certainly thought about herpes. You mentioned DH. I'm not seeing that.
Yeah, and umbilicated like this, probably more viral. So I'd be over simplex or zoster. If it's zoster and crossing the midline like that, then you worry about 1, immunosuppression, and 2, dissemination of zoster. And, this was just a simplex herpetic glossitis. Quite possibly in someone who's immunosuppressed to have that kind of dramatic. Okay, Rob.
Second, I have ulceration of the raised polishes.
Okay, so it's something that's ulcerative. The border is annular, like a ring. It is raised, you said violaceous to pink. What other colors do you see in here? Yeah, like a bluish gray. So what kind of things can give you bluish gray pigment in skin? Where's the pigment located? Yeah, deep Tyndall effect, right? So deep Tyndall effect for lipofuscin, hemosiderin, or melanin. In this case, because it's an inflammatory condition, probably melanin. So it suggests what kind of histology for this? So if this is inflammatory, is this spongiotic inflammatory, or what kind is going to give you that kind of deep, heavy pigment incontinence? Lichenoid. And do you think that this is more likely, this is a tough one, an atrophic lichenoid or a hypertrophic lichenoid, given that they're indurated and raised? Hypertrophic. Well done. Okay, so it's a hypertrophic lichenoid process. So what hypertrophic lichenoid processes do you know about? Exactly, and that's it. That's your differential. You know, what ulcerates like that and is hypertrophic and lichenoid is going to be, I don't think the other things like lichenoid GVH and things, I've never seen them like this. So yes, pretty much this is going to be hypertrophic LP or hypertrophic LE. And how are you going to tell the two apart? What's the fastest way to get there? One is look in their ears and their scalp and things to see, you know, do they have discoid lesions in their ears? But other than that, what can you do lab-wise or biopsy-wise?
Just looking at the differences in paths, so you'd see like LE superficial infiltrate.
Except usually not in hypertrophic lichenoid. They're dead ringers for one another. Sometimes more atypia, almost Ka-like in the follicles and hypertrophic LE. That's a very characteristic look. But pretty much, usually, they're dead ringers for one another. But go right for IF. DIF is where the money is. LP, you're going to see shaggy fibrin. And in LE, if it's hypertrophic, you're going to have a strong, granular, full house, probably with follicular involvement of IgM, which is then pretty much, so full house means everything's there. C3, IgM, IgG, everything, and M extends in a granular fashion down the follicles. That's essentially pathognomonic, you're done, that's lupus. And then treatment of hypertrophic lupus. And you can call on a second or third year because they know everything at this point.
I was going to say Plaquenil.
Yeah, you can try with Plaquenil, and it may do some good. It's seldom, bless you, it's seldom enough in my experience. Not for the hypertrophic ones. And important thing is the hypertrophic ones drive aggressive metastasizing squames. So you really need to shut it down. So Plaquenil is probably going to be part of it. Don't forget intralesional, because you actually get a lot of mileage out of intralesional steroid in these. This is one where soriatane can certainly help. And then other immunosuppressive agents, azathioprine, mycophenolate, all of those things can be very helpful in that case. Okay, that is a belly button. Sister Mary Joseph nodule. So Sister Mary Joseph or Sister Joseph was at Mayo and described, I think the original she described was gut, gastric to the umbilicus, but it's usually gastric or ovarian are the two most common that go there. That's exactly what it is. Okay. Jessica, this guy shows up in your clinic. It's been biopsied. They said it was a squamous cell carcinoma, and he is scheduled for amputation in orthopedics tomorrow. And he's coming into derm because he wants a second opinion. And this grew rapidly, and there is no acantholysis, and there is central hypergranulosis, and there are neutrophil microabscesses and elastic trapping. It looks like a KA. So again, the question is, this is a Robert Wood Johnson case. So we had at Slide Conference looked at that giant keratoacanthoma, And so they treated him in the clinic with intralesional methotrexate, and there he is. And he kept his finger. So again, I ask you the question, do KAs exist as a distinct entity from squame, and does it matter? I would say this guy would argue, yes, it matters, which is why smart people like Joel keep a bottle of 5FU in the clinic, because sometimes, the only way you would do it is amputation. And KAs like this, 75% of the time, roughly, have perineural extension. So if you try to Mohs them, you're going down the neurovascular bundle, taking it out, and basically you can't Mohs them out because they have extensive perineural extension, and that does not make them a squame. That's characteristic of keratoacanthoma.
So there's some reports where KAs in the finger would cause bony destruction.
Yeah,
have you seen that?
They can cause bony erosion,
Okay.
and again, that doesn't make it a conventional squame. So the perineural doesn't. The acantholysis does. It's not going to involute if it's acantholytic, but something that otherwise looks like a squame. And for this one, it actually had mixed features, but it had very prominent elastic trapping. And so we actually did a study on the heels of this, and your elastic trapping alone, it's not that squames never do it, but your likelihood ratio, 2.5 times more likely that it's going to behave like a KA than like a squame. And we talked to him, and he basically said, they're going to cut off my finger tomorrow. I have nothing to lose by your injecting it. And he had pretty rapid involution. So
yeah. Injecting 5FU methotrexate into a conventional squame, what's going to happen that way?
They shrink. They shrink, but not all the way, and then they resume their slow, gradual growth after. But they never do anything. Conventional squames never do anything explosive. They're very unfazed by anything you do to them. Whereas KAs go away quickly, explode quickly. They're very, they're like teenagers, the KAs. Whereas, there's more equanimity in a squame. They just perkle on. But they will shrink some. So the fact that something shrank, you still have to watch it. But to shrink where it's totally gone like this, I've never seen that in a squame. In a conventional squame, because lots of people, the predominant terminology for KA is still that it's like KA type of crateriform squame or infundibulocystic squamous carcinoma. There are 20 names for it now.
I usually just curette them after a biopsy. Is that enough?
It can be, but so this woman, actually, that discussion came up. So she's, thank you, yes it is, a keratoacanthoma. And sent to me by a plastic surgeon because she was in the hands of the plastic surgeon, and the plastic surgeon sent her actually to see me. We had one exam room at Ackerman, and most of what was in the exam room was methotrexate and 5FU. And so this was a plastics guy who had in the past. He's actually a really smart guy. He's got a winter house on Daniel Island. When he found out I was coming here, he called and I didn't know he had that house. He just said, "You are my hero because you're doing what I want to do, move to South Carolina." But he's a nice guy, smart guy. And so he sent her in just saying, you and Pat call these things KAs sometimes, and I know we're not supposed to touch them surgically. Is this one of those? So she also has a peau d'orange type of sebaceous skin texture. That, after curettage, looks horrible. Basically, anything you do to create a contour defect on that kind of peau d'orange sebaceous skin looks awful. linear closures or any kind of suture closure look horrible on that kind of skin. And she has no crease to hide it in because they furrow any type of linear closure that you do. So they're going to look crappy. We had, yeah, look at that. And it turned it into an abdomen. In one of the future sessions, we've got the follow-up photos. She had a little bit of shallow cribriform scarring there. She decided not to have dermabrasion or anything for it because it really didn't bother her the bit that she had.
How was it treated?
Methotrexate. She also she had insurance, but she was wowed by the fact that with her insurance, her entire course of methotrexate cost her $1.25 because we didn't charge for seeing patients at Ackerman because we had no way to. We were a derm path lab. We had no way to bill for it, so that was just patients were seen gratis. So her entire course of treatment cost her $1.25. Yeah, you can't even ride the New York subway for that anymore. Yes, sir.
Question. When you're injecting, are you shooting for like X amount of volume into it?
No. So it's kind of like injecting a keloid. So when you inject a keloid, if you're putting it right into the middle of that keloid collagen, you accomplish nothing because that's not where it's proliferating. And if you put it right in the middle of a Ka, you're injecting it very nicely into a crater full of keratin and accomplishing nothing. What you're going for is everything that's peripheral to that core, and you're trying to blanch it. And if you're injecting into the crater, the thing doesn't blanch. And often it squirts you in the eye. It just comes out of the keratin and squirts you. If you can get into the flesh of it and make it blanch, you've accomplished what you want to accomplish. Same thing with a keloid. You don't want to be quite dead center unless it's a very young keloid or hypertrophic scar. You don't want to be quite dead center. You want to be a little off center in the proliferative part, not in the sclerotic bubblegummy collagen. And you just want it to blanch. So as much volume as it will hold to blanch, that's what you're going for. And just like a keloid, they get softer after the first injection and they're easier to inject.
Do you do weekly?
I do weekly, correct. Yeah, weekly until it goes. And then for hers kind of waxed and waned. So it was shrinking away really, really well. And we just let it go, and then she'd call me like a month later and say, it's coming back a little bit. And so we knock it down again. It went on for like 3 months that we were, we started with weekly, and then we were monthly for a couple of more times, and then finally it keratinized itself to death and went away. But you see that histologically, where you have something that looks like an involuting Ka, except this side is proliferative. That's kind of what hers was doing asymmetrically.
Did you see any adverse reactions?
We had one of the residents. Was it you, Adam, who had a patient who said it hurt a lot after the injection?
The 5FU, she was very in a lot of sharp stinging
pain. And
she sent me a picture yesterday. I was going to tell you actually. So
yes.
We injected a little hypertrophic scar on her wrist. And she now has a brown patch all the way around it that's hyperpigmented.
Okay, that is something that 5FU can do. When you get no, it's not permanent. Okay. And if she doesn't like it, we can ND-YAG it.
Yeah. Okay. I mean,
and I would just do that gratis if we were doing that. So, and it suggests that maybe she had some injection under the lesion that diffused out, possibly, because usually, like when you see people who are getting 5FU for chemo, they have a very sharply delineated over the veins, tree-like hyperpigmentation. It's just where the 5FU is. I usually haven't seen. So that would be the first patient that I've had who had extreme pain, and the first patient that I've had who hyperpigmented. But I'm sure it was the drug because it's a known complication of infusions of the drug.
First injections, you know.
Well, and maybe also the last.
100% of your patients. That's right.
But also maybe the last time you ever experienced that was injecting it. Ask Joel too, because he's used it over the years, like I have, and lots of people have. Just see what other people's experience is. Okay, I think we have time for one more. I apologize, it's a short session. If this happens, one of the things that other groups would do is just take a conference from later in the week and move it into this and flip-flop the two. I mean, not that it happens frequently here, but in New York it would happen occasionally. The trains would stop. So, okay. So what do you think?
Is it me or Brian?
I guess because your KA was pretty simple.
A photo from a body shot. Like a.
You get a prize. You get a prize for the most creative. Photo from a body shot could actually conceivably describe this morphology and distribution. The only thing that I would say is the degree of hyperpigmentation is perhaps not what I would expect. But it is also, given the protuberant abdomen, you might expect the drip from the photo to have gone in multiple directions.
Oh my goodness.
True.
But who says people with protuberant abdomens can't do body shots? So, okay. So, what else might you think? Especially if this patient were in the hospital and ill. We're in the South.
Oh, is it like strongyloides?
Absolutely. That would be my top, would be a larvicurans of strongyloides. We're in the South. There was one paper that shocked everyone where the most common, this was in, just one period of time, the most common fatal disseminated disease of immunocompromised at Duke was disseminated strongyloides. Not aspergillus, not anything else. One of my professors who was from the South said, everyone in the South has worms. They just don't know it. Because it's contained by the immune system. And there are, when you look at latitude, atopy is much greater at higher, more northern latitudes. And it's probably because of the lack of helminthic infection that you don't have that that you don't have the downregulation of the atopy. There is one recent study where they treated Crohn's disease with trichuria eggs. Basically, they infected you with whipworm, pork whipworm. And it was as effective as conventional immunosuppressive treatment for the Crohn's.
12 indications.
So, very common, probably beneficial, because that's the way humans are supposed to live, is with low-level helminthic infestation. And the rising levels, the shocking levels of atopy and allergy in Western cultures probably has to do with our excessive sanitation, which is why we try to be really dirty at our house. Exactly. but in any case, strongyloides and larva occurrens would be my first. And with that, we've got to quit and get to clinic. So someone take note. We only made it as far as 98 on set 2. Someone put it into your phone, please.
Dr. Purvis, the VA guy, yeah. Okay. I actually pulled the other one. Okay. Dr. Purvis is bringing one.